Good evening. Welcome to Health Plus Weekly in our new studio. Thank you to New Bedford Guide for expanding and improving our studio. I am Dr. John Podkowa. I am joined by my co-host, nurse practitioner Hannah Raymond tonight, and we are also joined by two of Southcoast's best pharmacists who we are going to be talking about diabetic medications and fielding questions about them. We have a great show tonight. We want to thank everyone for tuning in. We want to thank everyone for kind of just increasing the popularity of the show. We encourage you to share it and like it and pass it along if you think the information is something that your friends or family may want to know. It was great a couple weeks ago when actually people wrote in and said where they were watching from, and Hannah and I got a great kick out of seeing what communities people wrote in from, so please do it again tonight to try to make the show as interactive as possible. We really appreciate the support. As always, we encourage you to write in questions via Facebook regarding diabetic medications, which we're talking to our pharmacists about, other medications, and of course general medical questions. Hannah and I are happy to do our best to answer them or point you in the right direction for the answers. Before we get started, we have just a couple announcements I want to make. It is National Nurses Week, for those of you who didn't know, so we want to thank every single nurse across the South Coast Health community for everything they do every day in touching and caring for patients. It's an amazing crew of people who we have working for us as nurses. We want to thank all the Spirit of Nursing Award recipients. They have been announced at Charlton and St. Luke's, and Toby's awards winners will be announced this Friday, so thank you very much. Also, on Thursday, May 17th, there's another Food for Tots drive at one of our local restaurants. You'll receive a discount, and you can visit our website and our Facebook page to find that out. And lastly, the American Heart Association's South Coast Heart Walk is actually Saturday, May 19th. It will be at UMass Dartmouth. It's a great way to get out into the community, walk for a great cause, stay heart healthy. And you can link to register that at the New Bedford Wellness Initiative Facebook page, and we're trying to improve and get people to turn out for that, because we know, and we've talked about what a great way to improve your heart health is via just walking.
I think before we get started, we deserve some recognition for the wonderful event that you helped to put on this weekend. This was the first annual Nicole Podkowa 5K race, kind of to benefit the Southcoast Cancer Center Patient and Caregiver Fund. It was a huge success, so I just want to congratulate you and Kathy DeSonis of the Cancer Center for all of her hard work and all of the volunteers. It was a spectacular event. Can you kind of give us your take on it also?
I am still on cloud 9 about it. Thank you for asking about it. First of all, thank you for the three of you for being there with your families and supporting it. I could not have asked for a better day. It was perhaps all the greatest people in my life were there, supporting South Coast, the Cancer Center, which is of course near and dear to my heart, who then took amazing care of my wife. And the fund, goes to people who are afflicted with cancers and their families to help them go through not just the cancer diagnosis, but the things they need in terms of, transportation, help with utility bills. So it goes to a great cause. And yeah, the Bay Club did a phenomenal job in hosting us. I thank them again, but I'll thank them again now. And all the volunteers who made it great. We had 500 people register it before we had to actually shut it down because we weren't sure about how many people we could handle. 400 people ran. The weather held out. It didn't rain. And
it was immaculately organized.
Yeah,
they
was.
did a wonderful job.
Yeah, did you guys have fun?
So many people.
It was a great day.
Yeah, it was very, very fun.
And it's going to be, we're going to have the event next year, which I'm looking forward to. So for everyone this year who came, and we hope to see you again, and we hope to expand it to more people next year. So,
and I think you actually, your sons swept the race,
actually,
right?
yes.
I think all of your sons placed.
Yes,
and
they
did really?
did some running and preparing for it.
Yeah.
Kind of was their way to get in shape for the summer. So
Good.
it was
the
nice to
spirit
have
of
them all
competition was
there.
out. I was really
It was
impressed
good.
with, some people were super off and running and planning it. I was worried about all the details of the whole event and then I was like, oh my god, I actually have to run this. It was funny. I didn't really forgot about the actual running, the running component of it. Fortunately, our youngest son JJ stayed with me.
He was your
and
pace
didn't
car.
leave me. Yeah, he didn't. Our oldest son, took off.
Yeah,
and,
He did well.
He did a nice time.
Yeah.
Your oldest son did, sure.
So, but thank you. So, Linda, Amy, thank you for coming on. we typically start our show with having our guests kind of introduce themselves and who they are and what made you choose kind of how, your role in pharmacy and how long you've been at Southcoast and what kind of brought you to Southcoast. So who's first?
I'll go first. I wish I had a more interesting story in how I became interested in becoming a pharmacist, but I knew I wanted to be in the health profession. And when I was taking my SAT test, pharmacist was one of the choices under health profession, and I hadn't really thought about it until that time. And once I did and decided to go into pharmacy, I went to Mass College of Pharmacy, got my bachelor's degree.
And that's in Boston.
In
right?
Boston, yes. It's now MCPHS University.
That's right. Okay.
With multiple majors.
Your degree's been upgraded.
Yes, it has been.
So you're from this area?
I am from New Bedford.
Okay.
Yes, born and raised.
Okay, great.
Yeah. Do you want to hear more about the
No, and then how long have you been, so actually, just in terms of the training, actually it would be great. So undergraduate and then postgraduate training, how long is it?
So back in the day, it was a bachelor's degree.
Yeah,
it was a 5-year entry level. You had no choice but to do a 5-year bachelor's degree program. And I think prior to that it was different, but when we went to school it was
I think when I got out, you had the option to go for your PharmD, and I would say maybe 5% of the class would go for their PharmD.
Okay.
Yeah,
So when I was there, when we graduated, it was a post-BS PharmD, and they also, at that point, started a track where students could decide at that point if they wanted to get a PharmD degree or a BS degree. But eventually they were going to phase that out, and it was going to be all the entry-level PharmD. So all the students that are committing today to pharmacy school are committing to a 6-year doctor of pharmacy degree.
Okay.
Yes, and they do offer a non-traditional, there was a post-BS PharmD program for those that kind of missed that transition. So that's the training that these students
So Amy,
get.
did you have a similar kind of path in school?
Well, pretty much I started working in a pharmacy when I was 15 years old.
Okay. So
So
no
from
the
there-
SATs didn't do it for you?
No, from there, that's what led me to pharmacy school, and then
And are you from this area as well?
I'm from here. I've grown up, lived in this area all
Great.
my life.
Love
Yeah,
that.
it's a nice area.
Yeah.
I love it here.
So then same thing, right? So kind of you going into college, the pharmacy was,
5-year program,
Yeah.
and from there I went on to do a lot of retail when I got out. But that's when I saw pharmacy start to evolve a little bit. We're starting to come out from behind the bench and into patient care with diabetes education, medication therapy monitoring, immunizations. We were giving immunizations.
Great. I think that's a really important kind of topic to cover too. Like, so we all know about the pharmacists who are, at the local drugstore, like you said, behind the counter, behind the bench. What are some other, other roles where you would find pharmacists?
I would say the hospital pharmacy. There's clinical pharmacists on the floors, and I'm sure Linda can attest to that.
Had you worked as an inpatient pharmacist as well?
Yes.
Great.
Yeah, most recently I was working as an inpatient pharmacist and doing clinical work.
So does that,
as
you
well.
just kind of check, all the orders that come in on the inpatient side and, available? I used to frantically call the pharmacist, with any questions, and you are our greatest resources.
There are all
as a
different
nurse.
assignments for the inpatient pharmacists. There are some that are working in the IV room. Some are up on the floors doing consults and assisting with dosing and monitoring of medications. There are pharmacists who are verifying orders and reviewing medication profiles. There are some up on the floors that are providing med reconciliation and doing some counseling prior to discharge.
So when the patients are either coming into or leaving the hospital, making sure that everything kind of lines up and everyone's
clarifying
clear
a lot
on
of
new
the orders.
medications or medications that have been stopped, which is in primary care a hugely important piece of the transition from inpatient to outpatient. So we have a comment from Angela who said, "We love all the support from our pharmacists. Thank you for all that you do!" Exclamation point. So
Thanks,
you
Angela.
guys are a great resource.
we have been really fortunate to have both of you working in our practice for how many months now has it been?
It was the beginning of
About
October.
8 months, maybe
Yeah,
6 to 8 months.
via grant, and it's one of the great things about South because we have these different opportunities, and so we know you're not just working with our patients, but for Hannah and I and for the doctors we work with, it's been fantastic. And hopefully you feel the same way, right? Like in terms of,
absolutely.
yeah.
And if you don't tell us
care.
now because everyone's watching.
We'll save that for later.
We do.
Yes, it's great to work with them, and I'm learning from them as, where we can fit in and expand our role.
And I think working with our diabetic patients, perhaps is that probably the bulk of who you're working with right now in our practice?
I would
you say?
Yes, yes.
Yep. I
And
think
then
just
some
having the
random
large,
questions.
just the sheer amount of patients that have diabetes, even if they have other conditions or they're coming to for other reasons, the diabetes part is an easy thing for us to get involved with.
Oftentimes we see patients, Hannah and I, and in traditional fashion, it may go usually it's like 3 months, sometimes 6 months before we see people back, and you try to make changes in the room with them and you talk to them, but you only have a certain amount of time.
It's definitely
and
a gap.
there might be other things they have going on in their lives at the same time. So one of the beauty of having you interact with people is the high touch in between appointments to check in with them. And how have patients received it? Like, what's been the experience with you guys? Have they?
Very well.
Yeah, very positive experience. Some people get a little choked up because they're so glad that someone's reaching out and caring.
And taking the time to listen to their concerns,
And it's very time consuming. So on an everyday basis, I don't know how, someone could follow so stringently.
But for the patients, we see how hard they're trying to take care of themselves. And they're very willing to share. And I know you've mentioned it before, how you feel kind of special that you can be someone's doctor and take care of them. And I know that we feel the same way. The fact that they're welcoming us into,
they let you into their lives.
Yes, and we're calling them and explaining how we're working with you to help take care of them. And they share information and take time to speak with us. And we try to provide them with whatever help we can, because ultimately they're the ones taking care of themselves. And, when we then try to sometimes let go a little bit and back up, sometimes they feel like it's helpful to them too, to have that accountability and to maybe continue to report things to us and have us check in. So it's a nice relationship that we're able to maintain as well.
So for people, so this is kind of how our patients in our practice and throughout Southcoast are kind of utilizing the services of you two. For people who are in the community and maybe not a part of the practice or have access, how would you recommend that they use like the community pharmacists or the pharmacists at the places where they get their medications? Could they use it in the same way? And kind of contact people with questions?
Yes, contact the local pharmacist. They can help you with any adverse reactions, any kind of barriers to obtaining your medications is another big problem that you need to try and overcome.
So the cost of medications, the co-pays associated with medications.
There's some different programs out there that have co-pay cards, but that doesn't always work for a big population of Medicare patients who can't afford their co-pays. There's other like Needy RX and Good RX or some other online programs you can try to apply to and find medications.
Okay, so if people are having trouble affording their medications and the copay, Needy RX, and what was the other one?
GoodRx.com.
GoodRx.com to sign up for some assistance programs. And then oftentimes, I know that this is something that I learned from working with you guys, going to the manufacturer's website of the actual drug.
Exactly.
You can print out or download a coupon or a copay card that can actually provide some assistance, and it's usually for a year. Is that correct? A year's worth of medication that can assist with the cost.
That they have you reapply, but more often than not, you can get another.
It's not just a year that
No, they do it kind of a year at a time, and then they'll do it again.
And we always recommend, because a lot of times on the ordering, clinician side, you're not quite sure what the cost of the medication is going to be. So I always encourage people that, if you get to, I think this is going to be okay, but if you get to the pharmacy and it, is just prohibitive to pick up the medication, call and let us know, because we'll try to work something out too. So I imagine if people kind of, get that far to their local pharmacy, they should, do the same thing.
That's a good recommendation, because sometimes the medication isn't cost and the patient isn't covered, and the patient will walk away, and then you don't realize that until the next office visit.
Yes, we found that
they
a lot.
haven't been taking it, and they didn't realize, if they could follow up. There's a lot going on in the pharmacy, so a second follow-up to get
we don't expect patients to pay more than, I would say, $20 to $30 for a medication, and if they do, they would maybe pause and call us first that we can adjust the, you know what I mean, adjust
Yeah,
the
the
medication and switch it to a different
communication.
brand, because there's a lot of interchangeability with, hopefully, thankfully, with a lot of the medications. So not always, right? We
Right,
know. I mean,
right.
with
No.
insulin, you know, it's frustrating. But in some of the newer medications, which we can talk about tonight, but fortunately, the older medications that have been out for a number of years, many of them are generic now, correct? Work pretty
Yes.
effectively, right?
Yeah,
right.
As part of what we want to talk about tonight.
One of the problems with when you say, you know, one copay up to $30, that's one medication.
Yes.
And when you stop and you say, oh, $30, that's not so bad. You know, I had a person say that to me once, oh, well, that's not so bad of a copay, and well, by itself, that's not so bad of a copay, maybe for a one-time prescription, but if you add that with 3 or 4 other chronic medications,
Yeah.
and you're filling them for a 30-day supply every month, that can quickly add up.
And we know that's a real phenomenon where people will juggle their medications. They will take
Yes.
some month and some the next month to try, and yeah, it's a real problem.
Combination medications are sometimes beneficial.
Yeah,
You have
it's a
two
great idea.
medications
That's a great-
in one,
yeah.
and then as far as compliance goes, they only really have to take that one medication to get 2 in.
So we
Mhm.
see
So it
that a
cuts
lot with
down on
blood
the
pressure
burden.
medications and then also some anti-diabetic medications
Right,
too.
so they're
Okay.
combination products.
That's a great idea. I hadn't thought of that.
Um,
I'll just write that down real quick.
So diabetes, you know, and I think we'll focus with, you know, mostly type 2 diabetes, which we've talked on the show. And the difference, you know, for people tuning in tonight, there's type 1 and type 2 diabetes. Type 2 diabetes is when your body makes insulin, and kind of reviewing, you know, what is diabetes, what's the trouble with sugar, we can walk through. Our bodies need sugar to run. You know, it's kind of the fuel for our bodies, especially the brain. Other parts of our bodies can convert certain other things into sugars, but our brain especially needs sugars. And so when we eat and the food goes into our stomach and through our intestines, one of the things that happens is foods get broken down into the sugars and they get absorbed through our intestines into our bloodstream. And then when the sugar gets in the bloodstream, it has to get put into cells so it can be used. And insulin is what our body uses to take sugar out of the blood and put it into cells. And I always, with my patients, liken it to like a gas station phenomenon. Like your car runs on gas, you pull into a gas station, the gas is underground in the tanks, and the gas pump takes it from underground and puts it into your car. And the difference with type 1 diabetes is when your body no longer makes insulin. It would be like the pump just doesn't work, or someone took away the pumps and there was this big problem in that you had to fill the car other ways. Or type 2 diabetes, which is more common, is your body still produces the insulin, but it doesn't get into the cells as effectively, and for a variety of reasons.
Yeah.
So we can talk about both types of medications, but the one we see more commonly in the clinics is type 2 diabetes. And we feel really comfortable with treating it in primary care. So some of our medications that we use, maybe we can talk to tonight, but and people are nervous, right? When
Right.
they hear the diagnosis of diabetes, they
They immediately think insulin,
Yes.
no matter what,
Okay.
type 1 or type 2.
Injection.
Yep, do I need an injection?
Right.
And if it's type 1 diabetes, that is the case in so many ways, whether it's a pump or a pen. But for type 2 diabetes, that's not always the case, and kind of pretty rarely the case at the very onset of diagnosis.
Right.
So the certain medications that we have, as Dr. Podkowa mentioned, kind of work in the ways where your body has kind of is declining in its own function. So it helps, decrease the insulin production, helps your body use the glucose that's in your blood.
And depending where your blood sugars are, we always try to get people to maybe change their lifestyle, talk about what they're eating, maybe losing some weight. But when a certain point comes and we think we need medications, my favorite, first-line diabetic medication is metformin. So I think it's most of our favorites, So can we talk a little bit about metformin and its history and what it does and why I think it's my favorite drug? So I don't know about how you guys feel about that, but I think it's a really good
Partly,
drug.
I think it's your favorite drug because a lot of type 2 diabetes, their body isn't responding to the insulin. I like to say the gates aren't opening in the cells to let the glucose in to give you energy. So with metformin, it makes those cells a little more sensitive to that insulin to get the glucose, the sugar where it needs to be.
What else does it do?
it stops your liver from putting out additional sugar. So I always explain to patients that even when you're not eating, your body has to put out a little bit of sugar all the time, or you'd drop.
Yes.
if you weren't eating constantly.
Yeah.
Although I think we do a pretty good job of eating.
So I don't tend to drop that all. From an evolutionary standpoint, I always tell my patients we didn't always have ready meals available. Like the saber-toothed tiger was not always available to kill.
Right, exactly.
So our body stores. That's a really important thing, though. In between meals, our bodies,
you're always putting out a little bit of glucose, and the metformin slows that process down, kind of counter. And decreases that amount of glucose.
Yeah, because the first place we store extra sugar is actually in our liver. One of the things people don't realize about the liver is multifunctions, but it stores extra sugar in the liver, and then our bodies also store it in peripheral tissues. So if we have too much sugar to begin with, we don't need any more in between meals, and so that's how metformin works there.
So it actually doesn't cause the pancreas to produce more insulin. So that's kind of an important thing that we talk about with our patients who are just starting metformin. Is everyone also associates, or many people associate, diabetes with low blood sugar, no matter what, no matter what it is. And for type 2 diabetes, the low blood sugar comes as a side effect of medications. So metformin, kind of the way that it works, has a very low risk of actually causing low blood sugar, because it doesn't, cause the pancreas to produce insulin and actually lower the blood sugar. So it's a good option in that way too for the first medication that somebody has. Yeah.
It's when first according to the American Diabetes Association, which is pretty much the standard of care, right? Gold, lifestyle and metformin are the first choice.
The first choices, yeah. And it can actually be used in people to prevent type 2 diabetes with many, many risk factors. We don't do that too much, but for a lot of people.
Are there anyone who it's not appropriate for in terms of patients in your experience, in terms of what patients may not be a good candidate for metformin?
Well, one important limitation is with a person who has kidney impairment, because your body can accumulate. It is excreted that way out of the body. And that was one of the reasons people were cautious about using it years ago. And what they found was that when it accumulated, it was causing some serious conditions and problems that had resulted in death. But they found that those patients weren't really the appropriate type to be on the medication in the first place. And if you don't have good kidney function, then it's really not a good medication to use. Also, if you become dehydrated and you don't have good intravascular stores of volume, fluid, then you can be at risk of developing lactic acidosis. So it's important that if a person does become ill with some type of stomach
like a
illness
GI bug,
or something where they're sick, or if they have congestive heart failure and they're intravascularly dry, they don't have enough fluid, then often the medication will get held or stopped during that time when they're sick, because it really then could cause some type of adverse effect that it wouldn't routinely. So given to your average patient, it's a very appropriate medication, but it is something to think about.
And it's important and that's why we want people to come in depending on how stable they are, every 3 to 6 months, to check certain things when you're diabetic, regarding how your kidney function is doing, how your liver function is, to make sure you're not dehydrated, you're staying, that everything's kind of working appropriately. And also to always let people know, if you're in the healthcare setting, what medications you're on, because if you go for certain procedures and whether you're receiving dye or things that could affect your kidney function, it's important because we hold metformin. So
metformin can cause some GI side effects, some nausea, diarrhea. By taking it with a meal, if you're taking it twice a day, you would take it with breakfast and with your dinner.
And that's usually if we...
There's also, you can have an XL, a long-acting version, and that sometimes helps with the GI side effects, so tolerating it.
And they usually kind of subside, too, if you can get past the first. So we tell people to either call us and stick with it, and they oftentimes subside.
It's such a great medication.
It is.
And there's usually some weight loss associated with it, so it's another great thing for type 2 diabetics, which we'll get into, but it can help you lose weight. And I tell people there's a bit of the taking your appetite away, that kind of a little bit of the don't quite feel, which helps to lead to some of the weight loss, which is good for type 2 diabetics as well. And yeah, the diarrhea, I think, is, in my experience, is the rate-limiting step for some patients. But in your experience, we usually start low, right?
Start
The
low,
doses.
slow.
Yep.
Yeah, because it's not, really, there's no sense of urgency in that case.
Yeah.
Because if you start right at the top dose and they, have a problem with it, then it's difficult to convince someone to go back. But if you start with a once a day and then build up to the twice a day and higher dose if needed, it's generally better tolerated.
And it's inexpensive, it's generic,
Sure,
it's, it's on the $5 list at Walmart, I know, and some of the other pharmacies don't even need a prescription for, or an insurance plan from it.
And you can expect, so the measure of, kind of how we monitor how well diabetes is controlled is the blood test measuring kind of the average blood sugar of the last 3 months, which is the hemoglobin A1C. And with, actually had a patient today who was started on the low dose of metformin 3 months ago, and his A1C came down a full point, and a little bit more than that as well. So I think it's 1 to 2 points it can come down, kind of with the maximum.
And that's a nice number.
Nice
when
number,
you compare it to
yeah.
the other medications.
Yeah. So it's
so it's one of the most effective in terms of lowering blood sugars.
And one of the nice things too about metformin is you mentioned it doesn't cause low blood sugar.
Right.
Go ahead.
Yeah, no, you can go ahead.
So people don't have to necessarily check their blood sugars. In the beginning, it's kind of overwhelming. And you tell a new patient they have a diagnosis of diabetes, and there's kind of a lot of things they have to eventually start to do, and they worry about checking blood sugars, and we want them to check their blood sugars. But it's not like we adjust the dose based on their blood sugars, which you do sometimes with insulin or other things. So it relieves some of that burden because they're not going to go low. Because,
again, the mechanism doesn't involve stimulating the release of insulin from the pancreas. So another factor, something that is a consideration, is by the time a person gets diagnosed with type 2 diabetes, often half of the beta cells in their pancreas that make insulin are destroyed because you're able to compensate for a while before it finally catches up to you and your blood glucose starts going high. So even with the medications that help to stimulate your pancreas to release insulin, they eventually may stop working because you eventually don't have enough of the ability to produce the insulin.
So the pancreatic cells aren't actually functioning well enough to make a difference.
They can't. So no matter how much you push them along and try, they can only do so much. So if you are working on it from the insulin receptor end, or the don't put out so much blood sugar from the liver, you can get a better response in those patients that have more the insulin resistance.
So there, kind of are other medications that we use pretty frequently, and usually in addition to metformin, if we haven't quite achieved that good control of the A1C that we're looking for, that actually do stimulate some insulin production from the pancreas. So what's a common medication that we would kind of use, like second line?
Well, glipizide. I don't know if it would be second line, but it does stimulate the body to release the insulin. There are limitations to such medication due to the side effect of hypoglycemia.
So that would be something that we'd want somebody to know how to check their blood sugar at that point,
and
too.
For the elderly, you would want to be more cognizant of prescribing that.
And we have heard people that will take it and then forget to eat or
That's
not eat,
problem.
and it doesn't care whether you ate or not. It starts working and starts lowering. Other people I've heard eat and then take it, hours later. So at that point, you kind of miss that first.
So these medications are, glipizide or glucotrol, glyburide is diabetes, one of the older ones. There is glimepiride, which is one of the newer, which is, is Amaryl, so they're on. And, most patients don't want an injection, want to treat the diabetes orally. And we try to do that in terms of the guidelines, and there's different kind of branches in whether you want to follow after metformin, if you want to add another oral agent or not, or another kind of pill, if you can, depending on where people's blood sugars are and if we think there's room. So, or if someone doesn't tolerate metformin, if the diarrhea is so bad, if they're just like, it makes me too nauseous, we typically stop it. So this type of medications, how do they work? Like, the sulfonylureas or this class, which no one really needs to know the name of, but like, how do these other type of medications work? What do they do?
They stimulate, they cause your body to release more insulin. so that you can use the blood glucose that is in your bloodstream, get it into the cells. It actually stimulates insulin, and insulin is what you need to get the blood glucose into the cells for energy. So at some point, depending on your beta cells and the condition, it has a duration of use.
Okay. So as Linda mentioned, so kind of when you develop type 2 diabetes, that kind of the diagnosis about, we know that about 50% of the functioning cells of your pancreas have declined. So over time, a medication that would, stimulate the insulin production from your pancreas requires functioning cells. So, like you said, as time goes on, those medications become less effective in how they, lower blood sugar. So that would be probably, if you're finding that you've been on the medication for a long time and it's not working quite as well, or would you see a rise in the A1C again, and maybe it's time for a change then?
Exactly. The medication might not be working as efficiently as it did, say 5-10 years ago when you were taking it.
You try to increase the doses and you don't get any more bang for your buck at some point, because you just, it kind of levels off, and it's just the progression of the disease.
It seems it still has its place in primary care due to the cost.
It's great.
More
low cost.
than I had thought.
It's effective. It also lowers, blood sugars by dropping the A1C 1 to 2%.
Yeah, which is a nice drop.
Which is a nice.
Exactly.
The biggest caution, and I would see this in the hospital on occasion, especially with glyburide, the chance that it can accumulate and hang around longer than it would, and we'd have people that would come in with, especially older people whose kidneys just aren't working so well, where the blood sugar would be low when they got admitted, and they would treat it, and hours would go by, and they'd get low again, and they, how long is this medication going to hang around? Because it continued to lower their blood sugar.
Yeah, when I was training at Temple in Philadelphia as a resident, I remember clearly a couple cases of this, and I had these amazing kind of couple great upper year residents who, an elderly woman came in, classic like summer, dehydrated, no air conditioning, got sick, got dehydrated, kidney dysfunction, went into failure, kept taking her medications because that's what her doctors tell her to do, right? It's the right thing, they're afraid. And then went into some kidney failure, and then wasn't eating as well because she was sick, and then kidney failure, you lose your appetite. And how closely we have to watch them, my upper year resident, because we got their sugars up, but we have to put them on kind of a drip of a kind of a solution with sugar in it around almost for 24 hours or longer to kind of let it all flush out. So just another important reminder regarding knowing the type of medications you're on, knowing that you should kind of make sure you're checking with your doctor and monitoring this stuff.
Especially with any type of diabetic, and with any medicated diabetic certainly, if you're sick, that's one of the kind of times to be a little bit more vocal and communicate a little bit more for those reasons. Exactly.
These medications we've seen, actually, you've been a great success in helping some of my patients who, and I would not have, I feel like I may have even asked this, but I wasn't perhaps not clear with my patients, but their numbers weren't getting better, but you talked to them and found out they're not taking them at the right times, right? Like it's really important how to take these medications. If you're on glipizide, when should they take them?
You should take if you're on a particular medication like the glipizide or the glucotrol, you want to make sure you take that before the first meal of the day. Yeah.
Or if you're taking it twice a day before. How long before? An hour?
30 minutes is generally recommended. I think it's difficult to tell a person an hour or...
Even 30 minutes is difficult because you want to make sure they eat. They can get distracted.
Right. I see as you're preparing it, if you can take it and then prepare it and then hopefully remember to
eat what you prepared.
I was talking to someone about that the other day, about how he forgets to take it before, because he was taking it after, and I asked him to take it before. And he said he was forgetting, so he told me where he sat when he goes to turn the TV on. So I said, maybe you need to put a little sticky note on the remote controller, just helping with adherence, some of those changes that, the best time to take something can maybe make a difference. Maybe it's that small amount that can improve it that you need.
There is sometimes confusion for the patient when they hear take it twice a day. I had somebody taking their glipizide at bedtime, and your blood glucose could go low. You're supposed to take that with a meal. So make sure you always clarify what does twice a day mean, and what is the timing of taking that medication.
So that we have a couple of questions here coming in, just general diabetes questions and also some medication questions. Kind of going back to developing diabetes, we had a question from John. What are some of the pre-diabetes symptoms that people should be aware of?
Yeah, great question, John. Yeah. So one is you might notice that you are urinating more. As our blood sugars get elevated, typically above 180, sometimes it overwhelms our kidneys, so sometimes people you notice that they're urinating more, and then that can cause you to become a bit more thirsty. Sometimes certain people actually can develop rashes. There's like this skin change phenomenon that can happen with insulin resistance, where you get these dark rings around your neck or in your armpits. Some people, I just saw that actually the other day. A woman thought she had a rash, and I was worried about it. I checked her blood sugars, and sure enough, she had kind of early onset diabetes. They call it acanthus nigricans. And sometimes some people can start losing weight. It's often more like necessarily not pre-diabetes or kind of in diabetes already. And sometimes vision changes. If your vision changes, that if you suddenly that maybe you should have your eyes checked, or if you've recently had an eye exam and then your vision changes shortly after that, I would certainly say things to get checked out.
I think fatigue is
fatigue is a big
feel tired,
Or maybe slow healing if you have a wound or a cut.
Excellent. Yeah, exactly. Another great, good point as well.
Your daughter Kelsey says hi, so she's watching. Hi, Kelsey.
Hi, Kelsey.
So that's good. No pressure. Teenage daughters never have anything bad to say about their moms.
No, especially not mine.
Since my mom's watching too. Yeah.
I love you, Kelsey.
And another question from Sarah. Hi, Sarah. Bruce did a great job today. She's recently heard the term dawn syndrome, where sugar rises early in the morning while sleeping. And is it common, and what would be our recommendation? So have you encountered that much, dawn syndrome, kind of the spike in blood sugar in the morning?
I think there's a bit of debate about what causes this, but certainly I think, like Linda and Amy mentioned before, depending on the type of medication you're on, after people go to bed and there's a long period where we're not eating, there's a risk of our blood sugars going low, correct?
It can go low overnight, and your body responds to that
with a rebound,
kicks
high,
in, gets everything revved up, and you can actually then overshoot and have a high blood sugar.
Right.
So if you only check it in the morning, you think your blood sugar is high, maybe you need more insulin or some type of treatment in the evening, but actually you went low, and that was the rebound.
The rebound from it, so your body's compensating. And so that brings up a good point, that with our diabetes educators with Southcoast, we've been seeing a lot of actually continuous glucose monitors for about 2 weeks, where in a scenario like that, it would be important where your blood sugar is continuously being monitored, so we can actually see that low overnight and then the spike in the morning, and not necessarily adjust the medication or adjust it in a safer way to not overcompensate for that kind of abnormally high reading in the morning.
The technology is really advanced in diabetes. And
one of the side effects, unfortunately, of these medications, this class of medications, is people can gain weight, correct?
Right.
Those that, especially the insulin, related to insulin, like you say, metformin has the opposite effect because it's not impacting the insulin release.
Whereas
but yes, weight gain
would be
so it's allowing your body to once again store that extra glucose.
And insulin is another one that would cause. They have new medications out now, a lot more new medications since when I was out of school. It works in the intestines and it actually causes weight loss. You feel satisfied, full, faster.
Yeah, let's talk about those. I mean, there's one other, but there's kind of the new and exciting. Like, things really changed. Probably over the past maybe 8 years is when these started coming out. So
and now they're starting to mix these with insulin, like your Trulicity. Mix it with insulin, it kind of takes away that weight gain from the insulin. It kind of replaces that bolus insulin that the patient may go on, which causes more weight gain. So these new medications are, they're very interesting, exciting, and to see how they
and some of the names of them are Januvia is probably one of the original,
one of the first
older, newer medications that came out. How does it work? What does it do?
So the when we eat, besides insulin, of course it's much more complicated than we make it, right? But there's a lot of different things. There's incretins and different hormones, the things that get released in response to the meal. And people with diabetes not only have a shortage of insulin, they also have a shortage of different substances that are important in insulin release. And one of them is actually broken down by an enzyme called DPP4. And a DPP4 inhibitor is this new medication, this Januvia or Tradjenta, Onglyza, and what these do is they allow your body to keep around this other important hormone a little bit longer, so that it helps to release more insulin. It helps again to stop your liver from putting out too much glucose. It may help you feel full a little bit sooner, so maybe you stop eating a little bit
continuously.
So again, that helps with controlling blood sugar without really putting you at much of a risk of low blood sugar, because it works when you eat. It's glucose dependent. So, and those are pills. Those are
nice.
tablets.
Yes.
So you're still not crossing over to that injection that scares a number of people.
So that would be good for somebody who, like you said, takes the pill but then forgets to eat.
Yeah.
So for someone who needs the blood sugar to come down but doesn't eat consistently because the medication responds only when you are eating. So that would be a
And
solution.
Januvia you can use with metformin and actually make a combination of tablets, which is nice, right?
Yes.
The Januvia, these medications kind of work on your glucose after you eat.
After you eat, right.
Kind of, a lot of the medications work on your fasting, meaning before you eat. But these are kind of starting to gear towards your after meal spike. And that's important because sometimes we get the fasting under control, and once you look at the numbers and you might be frustrated of why they're not going down, maybe it's time to add something for after meal as a combination product. So you're getting the fasting glucose and the postprandial. Yeah.
The after meal.
So since these combo medications, once you adjust, it's, usually you start them independently, figure out how much metformin they need or how much of these newer agents, and then you can see what types of combos are available, because like Amy said, a little more cost effective for the patient to take a combination if it's available, and if it's something too that the company may provide the same type of copay card for commercial insurance or some type of assistance.
These meds are pretty well tolerated also. You might have some GI effects, but other than that, the feedback I've been getting is that you're tolerating it without any issues.
And in general, the medications that cause the pancreas to put out more insulin do carry a slight risk of pancreatitis. So you can, you're asking it to work harder, and it can become inflamed because of that. So just kind of across the board with those.
History of pancreatitis, watch out with alcohol.
Yes.
And then kind of the next evolution of these they made, which was nice, are injectable. However, they work a bit more effective, and some of them you can even take as little as once a week, correct?
That's one. Yeah, that's a great option, and I'm noticing a lot of the patients. I was thinking maybe people would forget if it's once a week and more of everyday routine, but these have really caught on, the convenience of that once a week.
What's the once a week medication? Is it
Trulicity? Yeah, it's just once weekly.
So the thing with a once a week medication, when you're taking it daily, if you do have some type of adverse effect with it, it would go away quickly. The issue with these medications that are a little different than the Januvias and the Tradjenta is I tend to think of these as being a little more potent. They work a little bit better because they go right to those receptors instead of helping your body to keep the natural hormone around. This one binds right to those receptors. And so it works a little bit better, but also may cause a little more GI side effects, maybe a little more feeling full, which can be a good thing.
Yeah, there's some weight loss associated with it, right?
Weight loss associated with it. Maybe a little nausea. There have been some patients that have said, maybe not so much nausea as a little discomfort, but I think sometimes people have ignored that I feel full feeling, like I can't take another bite or I'm good, But people eat, and we all know that we eat sometimes not because we're hungry, but because it's good and you enjoy it, and you kind of ignore those feelings
Yeah,
of fullness. So if the thought is that this improves satiety where you feel satisfied a little sooner, and where you're not used to feeling that it feels a little uncomfortable. I feel
it's a really interesting thing. I talked to some of my patients about, we changing their habits in meals, and sometimes if you're not hungry, just not to eat. We're programmed, like our moms did a really good job. Our dads, like breakfast, lunch, dinner, you have to eat. But a lot of times if you're not hungry, it's okay, to perhaps not eat as much.
So if you start listening to what your body's telling you, that, maybe you have had enough, or maybe you don't need to.
Yeah.
So what some people would say is a side effect, if you kind of pay attention, maybe you just get used to that, you stop eating a little sooner, and then the weight loss comes and things start improving.
Right.
Are insurances paying for these, in terms of co-pays for patients? What's the out-of-pocket expense in your experience with these for patients? Is it?
I'm getting a range from $25 a month to $47 with Medicare.
Okay.
And usually it seems like in this area, the Trulicity is covered. I'm not sure, but in Rhode Island, it's more the Victoza is covered.
So
Okay.
again, working with your primary, or the prescribing clinician and the pharmacist to figure out what's the cheapest,
The preferred.
for your drug plan.
And what we found is that it changes,
Of course.
Right.
Patients
Right.
will
You get used to
patients
one
will get
thing.
used to one
Yeah.
thing. With insulin types, we saw that a lot at the beginning of the year when there's a new preferred agent and someone needs to adjust.
Yep, we get a lot of calls about that. We have another question from Kathleen asking stating that she's seen various articles on some of the problems of prolonged use with metformin. They suggest that it may lead to dementia and Parkinson's disease. Have either of you heard any studies or read any studies relating to either of those kind of long-term side effects of metformin? I know I haven't heard anything or seen anything.
I haven't read
myself
anything recently on
yeah.
that. And have you guys?
No, I had looked into the metformin and changes in mental status, and there was some concern about it initially, and what they ended up finding in the end was that the patients on metformin actually had better mentation, and I think it was felt to be related to the glucose control over time.
Yeah.
So I'm not sure that it's been found to be, a positive association.
Because it's not a black box warning. It's not a
No.
Yeah.
And then in addition to metformin too, just because again it's my favorite drug in terms of diabetes, there's a cardiovascular benefit as well. Patients who have been on it have been proven to have less cardiovascular outcomes, and perhaps also some anti-cancer benefit because there's an increasing link between insulin resistance and cancer.
Right,
So,
associations.
Right.
can you take the Victoza and the Trulicities with metformin? Do we use the? Do you guys
Yes,
see
you
them like
can.
Yeah.
Yes, that's
You wouldn't want to
fine
use a
combination.
Januvia with a
Yes.
Victoza or a Trulicity, but they can be combined otherwise.
And we have another question from Susan asking, are all people with diabetes all overweight, or is it genetic or a combination of both? And you did kind of answer your question there a little bit. So in kind of in general, type 1 diabetics, especially at the time of diagnosis, tend to be a bit thinner because there is
starving,
no, that's right, there's no
Yeah.
insulin production in their bodies, so they're kind of losing all of the glucose, and they tend to lose weight kind of as one of the main signs of type 1 diabetes. So for type 2 diabetics, not everyone is overweight, but certainly being overweight does increase your risk for developing type 2 diabetes, along with a host of genetic factors as well.
I would say from a hereditary perspective, type 2 diabetes, I think a stronger hereditary prevalence than type 1. So really important to know if your mom or dad or brothers or sisters have type 2 diabetes, that you are also at high risk for it. So to be kind of hyper vigilant about staying kind of thin, exercising. If you are a woman and you develop gestational diabetes, you should also be cognizant that you could be at higher risk for risk of diabetes later on. And there are certain ethnicity groups that are at higher risk for diabetes. So it was a great question.
Yeah, great question. Grace is watching too. Hi, Grace.
Hey, Gracie.
Christine Perry. Yep. So I think, and Tom Crabb too. Hi, Tom.
Tommy.
So we talked about kind of earlier today, we've talked a lot about the oral medications that are used for type 2 diabetes, and that, there is a time and a place where insulin is also used in type 2 diabetes, and certainly in type 1 diabetes. And we were talking about just how kind of scary the whole thought of an injection is, and kind of, drawing up the vial and making sure it's accurate. But you had kind of commented on some really neat kind of advances in the technology in terms of giving yourself insulin. So could you speak a little bit about, why people might not be so scared to, have that undertaking?
We've come a long way as far as insulin goes. You used to have your vials and have to draw up, and it was a process. And over time, they've come up with insulin pens, and literally making sure you have the correct needle on, you just dial it up. And
so you turn a little to the actual number. You don't have to look for the fine lines or anything like that. Okay.
You dial up to your the units necessary to give.
Which seems safer in general,
safer,
right?
It's more portable, so if you go to dinner, you can put that in your pocketbook. You have to make sure you store it correctly. But all in all, it's not as cumbersome as it was.
Okay. And what about the needles?
The needles are much more fine than they were then. So now upon injection, it's often not felt.
Okay.
Less problems with infections and things on the skin. So I think that the fear of the injection, I think a lot of people feel like if they have to go on insulin, it's it's really going to be a horrible experience. And unfortunately, if a person does go down that road, again, it doesn't mean that they have to stay on insulin forever. Something when you were mentioning about pre-diabetes, there's a lot of people that are walking around now that have pre-diabetes but don't know that they have pre-diabetes. And once it is diagnosed, again, that doesn't necessarily mean that they're going to go down that road if they're able to walk 5 times a week for 30 minutes, or do some type of exercise, or start, watching that food intake that they've been meaning to for a while, or and losing weight. We know also that you don't have to lose, 50 pounds to make a difference, but rather
10%
of your body weight.
I think I even saw 7% somewhere that can make a difference. If you lose about 15 pounds, it can make a difference, and that may mean, medication or no medication.
Great.
And there's something that we hear about too, just like clinical inertia. You mentioned you go 3 or 6 months before you see someone. So if someone tells you, I'm going to get out there, I'm going to exercise, I'm going to, and then life happens and people don't get to do it, and then they see you, and again, they're kind of in that, should I start medication, should I not? And then again, another 3-6 months, and before you know it, you have a person that's had diabetes for a year. But it's that taking that step from going from a pre-diabetes to, okay, now I think you have it, and now we need to.
And I think that's where the association of insulin and bad things happens for a lot of people, especially. It's getting better because the insulins are getting better, like we talked about. But for a lot of people who, I'm in my mid-40s, like, and a little bit older, they saw like their grandparents or parents have really bad outcomes with insulin, and they lost a leg right after it, or they died right after it. And the reality was, and they think it's the insulin that kind of led to those things, but the reality was it was just the diabetes that wasn't treated for so long. It was irreversible damage had already been done to a person's body. So what we try to say is, actually, it's not we just, before we get there, we want to get ahead of that to begin with. So let's start early. It's not a last resort. It's actually, in some of the algorithms, second line. It's metformin, and sometimes there's a lot of really good evidence that after metformin doesn't work for you, to switch to an insulin. It's simpler in a lot of ways. You don't have to, it's easier on some other body parts.
It's effective.
It's really
effective.
The
only problem is that it can be too effective. That's really the biggest risk, is the low blood sugar that you have to worry about, and that's just it working too well.
So another question, JJ said he's watching also, Dr. Podkowa, and he said you're doing great.
Thanks, handsome.
And so Fatima was wondering, and talking about insulin, how long can you generally keep insulin out of the fridge, or is it just dependent on what type of insulin it is?
It depends on what type of insulin it is, to look at patient information. There's so many different ones out now.
So that would be something that you could ask your pharmacist about, right?
Exactly.
So depending on the exact type of insulin, pen, vial.
Generally, the one that you're using is out of the fridge, and the remainder of the supply would be refrigerated. But once it's out, again, if it could be 2 weeks, could be 28 days, but depending on their specific pen or.
And we could have an entire show
I was just
on
thinking
insulin.
that.
Yeah, so
You guys would be gracious
you
to
look
come
pretty
back.
comfortable here, so
Yeah, we have a whole show on insulin.
that's great. We are all caught up on questions. We don't have any rapid fire,
No general medical questions tonight?
questions right now.
You're
No,
off the
no.
hook.
Great. Do we miss anything in terms of maybe something you want to make sure our audience knew?
We didn't talk about the SGLT2s. I don't know
Yeah.
if you're.
Oh, the other, we'll have to, we can do that on another night, I think, but
Okay.
yeah.
Along with diabetes comes a cardiovascular risk.
Right.
So controlling your blood pressure, controlling your cholesterol is
Right.
another important aspect of diabetes and everything else that goes along with it, and decrease cardiovascular risk and issues. So to try to keep your blood pressure down, take your medications appropriately, and also take your cholesterol medication. Some people don't really tolerate, or they claim they can't tolerate their cholesterol, say a statin. There are strategies, and it's worth a second try.
Right.
What are some of those strategies quickly in terms of people who had a hard time on Lipitor, hard time on something? What do you try to tell them?
Try to tell them, then you start decreasing the dose a little. And before they even start, you should probably generally find out what is the situation. Are you having any muscle pain at this time before we start this? And then as time goes on, if they start to develop any kind of muscle issues, they could actually decrease the dose. Some people do fine 3 times a week, and it still has a beneficial effect.
Right.
So
And there's sometimes switching the actual drug helps
Yes.
too, yeah.
So
Pravastatin.
cardiovascular disease is very important to treat and to take care of your lifestyle exercise, because that is one of the leading causes.
Most common
Of
cause
death.
of
Death and
death.
diabetes,
heart
disease.
Heart
Yep.
disease, yeah.
And now they have medications coming out, they're finding out that the cardiovascular, they help with those issues. There's
Yeah.
new medication out, it's now in the new standard guidelines that there's pathways to direct the provider
Right.
of selecting maybe a medication that's been proven for.
To be helpful. So again, keeping that close relationship, especially with
Yes.
new
Ask
onset
questions.
diabetes. So it's not just about keeping the blood sugar under control, it's about keeping
Yes.
heart healthy. We watch your kidneys, we watch your eyes, we watch your feet, your skin. It's a really important relationship to have.
I think it's one of the amazing benefits that Southcoast offers, that it's truly a multidisciplinary team that we have to care for our patients. I know Hannah and I feel really grateful that we have you guys to help with our diabetic patients. We have this amazing diabetic education program.
Yes.
There's other pharmacists involved. We work with great ophthalmologists and eye doctors in the community. There's endocrinologists for the really complicated patients.
Kidney doctors,
Yep, we have
nephrologists.
kidney
Yeah.
specialists as well. The bariatric surgery program,
Yeah.
actually, which we had Ray Kruger on in terms of helping our diabetic patients and actually being a great treatment option as well. So,
Dietitians, we said.
Yep.
oh my gosh, yes,
Yes, yeah,
Richard. Yep.
dietitians.
Heather Haynes has been on the
Yes.
show, so thank you. Hey, well, thank you very much for
thank you.
taking
Thank you
an
for
hour
having
us.
out of like a really busy lifestyle to
And
come
thanks for
spend.
letting us, knock on your door
Anytime.
anytime during the day.
We couldn't hide.
That's right. Can't hide.
Thank you, everyone, for tuning in. Thank you for the questions. Thank you for letting us know who was watching and where you're watching from. It's really great. One last time, happy National Nurses Week to all the nurses out there who take care of our patients every single day and we work alongside with. It's really, can't say enough thanks. And we will be back next week. We look forward to seeing you then. Stay healthy, Southcoast.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.
I had 2 blockages. I had to have a catheterization, and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.